Welcome everybody for the session titled Thyroid Cancer Trials 2023, a presentation live stream from Australia. We're here today with Dr. Matti Gild. I hope that's right. Dr. Gild is an endocrinologist at Royal North Shore Hospital, Sydney, Australia. Her clinical research is focused on optimizing patient outcomes in thyroid cancer, and she maintains her basic science platform investigating genetics of thyroid cancer. She works clinically at Royal North Shore Hospital as a staff specialist in endocrinology and as a senior lecturer in medicine at the Northern Clinical School. We also have Dr. Bruce Robinson. Dr. Bruce Robinson is an endocrinologist and professor at the University of Sydney in Sydney, Australia. He has been the head of the cancer genetics unit at the Coling Institute of Medical Research at Royal North Shore Hospital since 1989. His research has focused on identifying genetic changes which either predispose or directly cause endocrine tumors. And with that, I'll hand it over to you guys.
Okay, well, look, thank you very much for the introduction of both of us. Matti and I work quite closely together at the Royal North Shore Hospital. I assume, although I can't see, that many of the people who are online with us today are from Australia and or New Zealand. But if we have anyone from anywhere else, then welcome to you as well. So what I've done in the past and what I intend doing with Matti today is to just run through what has been published in thyroid cancer that I think is of significance to patients in the last 12 months. And then I'll throw to Matti and ask her to talk about a project that we are undertaking, led by Rory Clifton-Bly and Matti in Sydney and Laurie Worth in Boston, a project looking at the mechanisms by which people develop resistance to the tyrosine kinase inhibitors that are used to treat thyroid cancer. So, as all of you would be aware, the main two different types of thyroid cancer are medullary thyroid cancer, which is primarily driven by mutations in the RET proto-oncogene, and that can occur in families, or it can occur in a sporadic form as well, where even then, nearly 2/3 of patients actually have RET mutations within their tumor tissue itself. Now, in patients with medullary thyroid carcinoma, who only represent about 5% of all patients with thyroid cancer, there has been significant progress in the last 12 months, which we'll touch on, and that progress has to do with the publication of a study demonstrating that selpercatinib has superiority over cabozantinib in patients who have RET mutant positive medullary thyroid carcinoma. The majority of patients, of course, have differentiated thyroid cancer, the type of cancer which is treated with surgery, followed by radiotherapy if necessary, and radioactive iodine in particular. About 10% of patients who are treated in this way eventually become resistant to radioactive iodine treatment, which is the most widely used post-surgical treatment for thyroid cancer. And that group of patients is a group of patients who are now able to be treated with drugs known as tyrosine kinase inhibitors. Now, the main tyrosine kinase inhibitor that's available in Australia, that's on the pharmaceutical benefit scheme, and I know it's difficult for patients in New Zealand to access this, but I'm told by my colleagues in Auckland that they are able to access it, is a drug called lenvatinib. Lenvatinib was shown in this SELECT study published many years ago now, led by Martin Schlumberger from Institut Gustave Roussy in Paris. It was shown to provide significant progression-free survival benefit in patients with poorly differentiated radioactive iodine refractory thyroid cancer. That drug is in widespread use. We think that at any one time in Australia, there are about 100 patients who are being treated with lenvatinib. We have that data in an indirect way, but we think that that's roughly the number. And many of these patients now have been on lenvatinib for periods in excess of 5 years. Ultimately, many of those patients eventually develop resistance to lenvatinib. That is, their disease is no longer controlled by the drug. And it's that group of patients who have been of great concern to us, because ultimately we believe that many such patients will develop resistance to lenvatinib treatment. And so a further study was established by a company in California called Exelixis, known as the COSMIC study. And this looked at the use of cabozantinib as second-line therapy for people who had failed lenvatinib. And the goal of the study was to try to see whether there was any progression-free survival benefit that was given to patients who took cabozantinib once they had failed lenvatinib treatment. The results of the study are about to be published, and they were indeed positive. They showed a progression-free survival benefit of 11 months in patients treated with cabozantinib versus a bit over a month in people who were not. So now, fortunately, we have evidence, at least, for another drug, cabozantinib, having a role in the management of patients with poorly differentiated radioactive iodine-resistant thyroid cancer, those patients who have failed treatment with lenvatinib. And that's something that should give heart to people who are taking lenvatinib to know that ultimately, if their disease does become resistant, there is at least another drug that we can begin to try. Now, the other study that I'll touch on that is ongoing in Australia that I spoke about last year is the redifferentiation study, which is being run primarily by Professor Andrew Scott from Melbourne. So this is a study which is utilising drugs which are known to be able to turn on the little sodium iodide pump that exists on thyroid cancer cells to try to turn radioactive iodine negative thyroid cancer cells back into radioactive iodine positive or radioactive iodine avid cells, so cells that will take up radioactive iodine and make it a suitable treatment for those patients a second time round when it has previously failed. Now, that study is ongoing. I think there are about 6 or 7 patients that have been recruited to the study across Sydney, Brisbane and Melbourne. And some of those patients have had responses and some have not. But nonetheless, the aim of the study is to treat people with a drug which helps to turn on that sodium iodide pump. And that too might then offer patients who've developed radioactive iodine resistance the ability to be retreated with radioactive iodine after this particular treatment. It's quite an involved protocol and procedure. It does require people to be in good shape before they enter the trial, because the trial is quite rigorous with some significant side effects along the way, particularly for a period of about 4 to 6 weeks when people are receiving this treatment. But nonetheless, it too offers yet another opportunity for patients to be treated in a trial situation here in Australia and New Zealand if they have radioactive iodine refractory thyroid cancer. So really some bright spots on the horizon, both the COSMIC study and the iFirst study, which is the name of the study, the redifferentiation study. Both of those studies are now suitable or demonstrate that there are suitable alternatives for people who have failed treatment with lenvatinib. And the study in medullary thyroid carcinoma demonstrating that selpercatinib in patients who have RET mutation positive medullary thyroid carcinoma has very significantly benefit over and above that which you can obtain with cabozantinib, which is one of the drugs which is currently available in North America for that disease. Now, in Australia, just for clarification, the only one of the drugs that I've just been talking about, which is available on the pharmaceutical benefit scheme at the moment, is lenvatinib. There is an application being put forward now to get cabozantinib listed on the pharmaceutical benefit scheme. That is being heard at the TGA, at the Pharmaceutical Benefits Advisory Committee meeting on the 1st of November. And we should know shortly thereafter whether that application has been successful. In the meantime, Ipsen, who is the company which is distributing cabozantinib here in Australia, have, I must say, been very good at making that available to patients on a compassionate use basis. So we do have access to two drugs, lenvatinib through the PBS and cabozantinib through the compassionate access program for patients with differentiated thyroid cancer. And for those patients with medullary thyroid cancer, although we don't have any drugs listed on the pharmaceutical benefit scheme at the moment, we do have access to selpercatinib through a compassionate use program that Eli Lilly, who now own that drug, run. So we are able to access 3 different tyrosine kinase inhibitors relatively easily here in Australia for our patients with metastatic, differentiated and medullary thyroid cancer. So I might just pause there and just ask Matti if she wants to add anything to what I've just spoken about. And then, Matti, for you to press on and to just talk about the acquired resistance study, which you and Rory are leading here in Australia.
Thank you. Thank you, Bruce. And thank you to Gary for inviting me to come today. And it's lovely to meet all of you and be a part of this community. So as Bruce mentioned, and now we're so fortunate in the last five years to have access to these drugs and to be able to really improve all of your progression-free survival, and particularly with selpercatinib, to do it in a way that doesn't have too many side effects and people can really live, pretty normal lives, which is great. One of the things that is one of the future challenges that we're thinking about in our thyroid cancer research and our group, and many people around the world are thinking about, is the next step. And eventually what sometimes happens is after you've been inhibiting the genetic driver that's driving the cancer for so long with these treatments, a subclone or a little part of the cancer can escape from that. And the cancer can be quite clever and have different escape pathways to overcome that inhibition. And that's the resistance that Bruce is talking about with the tyrosine kinase inhibitors. And one of the studies that we're doing at the moment is to try and actually look for that resistance early and do that through some circulating tumor DNA, which we can actually get from a peripheral blood sample. So the same way you'd get your thyroglobulin or your calcitonin checked, you would actually be able to check potentially if there was any tumor circulating, and we could actually measure it. So that's something that we've got in the pipeline, and that's quite exciting. But then, of course, the next question is, how do we actually figure out which people are going to develop resistance? And this is the acquired resistance study that Bruce was talking about. So what we're doing is we've got a really large international group from, I think, Saudi Arabia to Boston to France to countries we hadn't even heard of, all over the world. And we're all trying to gather our data of everyone who's been on these specific inhibitors to try and determine what makes someone progress and have the resistance. And that will really help us determine whether we should start early or we should start later, and really help to characterize that maybe there's a molecular profile, the kind of genes that are mutated that are more likely to be resistant. So it just means that we can sort of be there in the background, ready to go with potentially the next therapy if resistance does develop. And that's the project that we're developing. I will also wanted to say that, and I'm being a little bit opportunistic here, I'm going to put my email address in the chat. And I chair the Thyroid Cancer Research Group, which Bruce leads at North Shore Hospital, and we are often looking for consumer people to which we'd like to meet with, say, twice a year. Wouldn't be a large a significant amount of time, because the research that we're doing, we want to make sure that it's relevant to all of you, and that's why we're doing it. We've got a lot of basic science work, but also clinical studies, and so it's really important for us to keep checking in to all of you that we're on the right track and we're focused to what's important to you. So if you are interested in being part of a consumer group, please send me an email on my email address, and I'll reach out to you soon. Bruce, did you want to take over?
Yeah, no, look, I think probably what we should do is stop talking now, Matti, and take questions. I can see there are a couple of questions in the chat. The first one is from Brian, and Matti really covered it, and that was, is there any knowledge of what causes the patient to develop resistance? So, Matti, you might actually just want to talk about how we think resistance does develop in a little bit more detail, and what some of the mutations are that we have identified in some patients who have developed that resistance.
Sure, no problem. So it's kind of, I don't know if any of you are familiar with the concept of antibiotic resistance, but that's sometimes the way that I think about it. It's when you are inhibiting. So the really good example is selpercatinib and RET inhibition. So RET is mutated and you've got selpercatinib, which or Loxo, which is what we sometimes call it, and it inhibits the RET. And so you kind of are pushing down the cell growth for such a long time. And then there's sometimes a subclone that can actually develop an escape pathway. So maybe the RET is sort of upstream and then it sort of activates a whole lot of things that go down to cause the cells to grow and proliferate and metastasize. So we stop that. But then if there are some cells that are able to develop a genetic mutation that can actually that can actually ignore the RET inhibitor, and they can actually start growing, and we call those a subclone. And what happens is we know with people on selpercatinib is that if you can imagine, I'm going to do a really funny puppet with my hands. So the way that the RET works is that you have ATP, which is like the energy molecule, and it binds into RET, and then RET will activate all the downstream pathways causing the cancer to progress. What selpercatinib does is it blocks the ATP or the energy particle, right? So it blocks it in. And what happens sometimes with selpercatinib is that the cells actually develop a gatekeeper mutation. So they actually stop the selpercatinib from coming in. And so the ATP or the energy particle can still come in and activate RET. And so what they've actually got in trials in the US, which we unfortunately don't have access to yet, is another second generation drug, like similar to selpercatinib, that can go underneath that gate. So I hope that was clear. But it's about, if you think of it as the cells themselves sometimes can be quite clever and make a subclone, and then they actually they actually have a functional block to the treatment, but we know this, which is kind of the point. And so we're thinking, and not me personally, but drug companies are thinking about second line and third line treatments that actually go around these blocks or these gatekeepers. And there are other drugs in lung cancer that have done this before us for many years. They have second, third, fourth generation. So we're kind of lucky because we can benefit from all the experience from the lung cancer doctors who've done this in NTRK inhibitors, which is another a mutation that occurs in occasionally in thyroid cancer, but also in lung cancer, and has a similar kind of concept of when resistance develops, say there's the gatekeeper that the drug can't get in, what's the next step? Okay, so we manipulate a drug that's going to be smaller that can go under the gate.
So in fact, add to what Matti has said, in fact, it was two patients from Australia, one of our medullary thyroid cancer patients in Sydney and a lung cancer patient in Melbourne, being looked after at the Peter MacCallum, who we were able to demonstrate this gatekeeper mutation development in several years ago. And it was when that was brought to the attention of Loxo, the company that developed selpercatinib, and then Lilly, that they were then able to do modeling. In fact, this is something that I suppose a lot of people don't understand. In the old days, if a mutation developed in a gene, you used to have to actually produce the protein from which that was made by that mutant gene, and then you had to crystallize it, and then you studied it with X-rays to try to look at how the structure of the receptor, or the lock, if you like, had changed. These days, that's sort of all passé. Most of this modeling is actually done on a computer. So by looking at the sequence of the amino acids in the protein, you can actually work out what the crystal structure would look like, and then you can design drugs very, very quickly, which are able to get in under that gatekeeper, as Matti said. And one of those drugs, which Lilly has at the moment, is the one that's in trial to try to see if you can overcome that resistance. So there's another question. So Margaret writes, do we know if Hürthle cell carcinoma spreads or has microscopic disease in another lobe, or does it tend to spread to lymph nodes or other sites without necessarily spreading to the other lobe? So, Margaret, the answer to that is selpercatinib tends to not be multifocal within the thyroid gland. It can spread to lymph nodes, and it can also spread via the blood. Hürthle cell cancer is one of the more challenging types of thyroid cancer. It is now recognized or renamed as oncocytic thyroid cancer. And there is a lot of work being done, particularly by a fellow called Ian Ganley at Memorial Sloan Kettering, where Matti studied in New York, to
Oh, we've lost Bruce. Oh, hopefully he'll rejoin us. In the meantime, I'll answer Brian, who said for lenvatinib, I believe Bruce mentioned 1% of patients that develop resistance. Is there a similar figure for sulfuric acid? Oh, hang on, here's Bruce. Yeah, there's Bruce again. We lost.
That was one of those irritating Saturday morning calls from Bairnsdale in Victoria. That's a nuisance call. What was I talking about?
Ian Ganley.
Oh, yeah, Ian Gantley. I think is he at Sloan Kettering or is he in Boston, Matti?
Not sure.
Anyhow, he's the guy who's led the group and published a lot on mutations that can occur in Hürthle cell carcinoma. And this is now a subject of study by ITOG. And I'll give ITOG a plug here. ITOG is the International Thyroid Oncology Group. And it's a group of people who are very committed to doing research. And Rory at Clifton Bly and myself are currently members of that. We hope to get Matti to be a member of ITOG before too long. It sort of regards itself as a rather exclusive group, which is both good and bad, but nonetheless, it's a group which has been responsible for initiating some of the studies that have really led to significant advances in the way we manage thyroid cancer. It's a group of only 100 individuals who are committed thyroid cancer researchers, and that group of people is looking very actively to try to see how we might be able to better tackle Hürthle cell or oncocytic cell carcinoma, which is otherwise quite a challenging condition for us to deal with. It sometimes reacts to radioactive iodine, but not always. It's often treated with these tyrosine kinase inhibitors like lenvatinib. And so for patients with Hürthle cell cancer, the availability of cabozantinib in the not too distant future as a second line treatment will be hopefully very helpful. So I hope that answers your question, Margaret. There's another question here. The lymph nodes. So Yvette has written, lymph nodes really capture iodine, especially when they are little. So the answer here is that, if I can see you again. So most thyroid cancer, particularly papillary thyroid cancer, spreads from the thyroid gland to the local lymph nodes in the neck. And they grow, the little thyroid cancer cells grow within those lymph nodes. And provided they retain the ability to take up radioactive iodine is very efficient at getting into those lymph nodes and killing off those thyroid cancer cells. So just because you have uptake into a lymph node doesn't mean it's a disaster, because radioactive iodine, if it gets in, can be a very effective way of treating that cancer at that site. Just the same as it can be very effective if there's uptake into a lesion in the bones or the lungs. Radioactive iodine, if it works, if it's still taken up by that little thyroid cancer cell, wherever it might be lurking, is a very effective way of treating thyroid cancer. Do you want to add anything, Matti?
No, I suppose, well, the only thing I would add is that sometimes your doctor might, in terms of the lymph nodes, they might want to go back in surgically. And I suppose just to say that that's also a very valid way of sometimes clearing the neck if you've got quite a few lymph nodes that are there on ultrasound. Sometimes we do that. Do we get rid of the lymph nodes, sort of more bulky disease if there's a decent amount, and then afterwards we'd give radioactive iodine to sort of ablate the microscopic disease. So we want to give it the best chance we can. So they're probably, you and your doctor can have a discussion depending on volume and depending on how many surgeries you've had, about which way is best.
So Margaret has written another question here, and that is it possible to have FNA showing Hürthle cell neoplasm followed by FNA 3 months later being benign? Would it just mean the nodule was sampled in two different places? Part of it has Hürthle cell neoplasm and the other tumour being follicular cells. So look, Hürthle cell neoplasm is a word which is used to describe often what are also known as follicular neoplasms, and many of these are benign. So the very fact that Hürthle cells, which are the cells that are loaded with these little energy factories called mitochondria, are present in a tumour doesn't necessarily mean that it's benign or malignant. The thing that determines malignancy in these follicular neoplasms is whether there's evidence of the blood vessels, which are supplying the tumour, being involved, or whether there's evidence of spread through the capsule of the neoplasm, the little skin that surrounds the tumour itself. So they're the two factors that determine whether you can really call something benign, unless there is very clear evidence of cell division or mitoses, which are the cells dividing that you can see under the microscope. So do you see these things being called Hürthle cell neoplasms one day and then 3 months later being called benign? Yes, that can happen. I think all Hürthle cell neoplasms need to be watched very carefully. But at the same token, we don't want to be taking out unnecessarily benign tumours in people if we can possibly avoid it. And so sometimes watching a nodule to see whether it grows in size, as well as whether there's any evidence on the needle biopsy itself for malignancy, often watching and observing it is a better way of deciding whether it should be removed than simply trying to decide based upon the results of a fine needle aspiration biopsy. Hürthle cell neoplasms are in a bit of a category of their own. And one of the things that is available now to help try and guide doctors and patients as to whether they should have their tumours removed is a genetic analysis of the needle biopsy material to see whether there's evidence of mutations within it which are associated with malignancy or mutations which are associated with benign tumours. That is available in Australia. It's not on the medical benefit schedule yet. It's called ThyroSeq, and we hope to be able to establish at North Shore in the next little while, hopefully 6 months, no longer, the ability to sequence some of this material from tumours that will hopefully tell us whether we're more likely to be dealing with a malignant nodule or a benign one. Margaret's now come back and said the nodule has irregular borders on ultrasound, but no vascularity in the nodule. How fast would a Hürthle cell carcinoma grow in size over a year? Well, these things generally grow, whereas benign things grow very slowly, Margaret. So any growth of more than 20%, I would be very concerned about leaving alone. I would be inclined to take that out. But Matti, you might like to offer your opinion as well.
Look, I mean, I think it's quite specific, patient specific, and you'd have to sort of see the previous ultrasounds exactly and get a bit of a sense of what's been happening and whether it's grown or not. So I think it's hard to sort of give general recommendation without more information. So probably, touch base with your physician. There was another one, sorry, that I was halfway through when you disappeared, which was just about the percent of people developing resistance on selpercatinib. So I'll just mention that. And the answer is we don't know, which is literally why we're doing this study. We want to understand how many people all across the world have been on these drugs, and then we want to know how many of them have developed resistance. And that's exactly the point, so that we can really we can figure it out. So the answer is we don't know yet, but hopefully we'll find out soon.
Okay, now Anne has written, what is our thinking on combining tyrosine kinase inhibitors with immune therapy? So Anne, this is a good question. The combination of lenvatinib and pembrolizumab has been trialled in patients with anaplastic thyroid carcinoma in a study that was run by ITOG, and a very marginal benefit of the immune therapy over the tyrosine kinase inhibitors alone was demonstrated. So on the basis of that, this is not on the pharmaceutical benefit scheme here in Australia, but there are some patients, a few patients, who have opted to pay for this. Correct me if I'm wrong, Matti, I think it's about $7,000 a month for the pembrolizumab to take in combination with lenvatinib. I certainly look after one patient who has chosen to do that. I looked after another patient who sadly passed away, who also used the combination. So it's a vexed issue still, is the answer to your question. Do you want to add anything, Matti?
No, yeah, it's tricky when you know, it's very tricky when these things cost so much money, and you know, there's emerging data in the States, and then we can potentially offer you the medication, but it's very expensive. So I actually haven't had anyone, because I only work in the public system, who has been on Pembro or has been able to afford it. But look, I mean, I think the take-home message is that there are lots of, you know, the last few years we've had a lot of advancements and a lot of opportunities, and a lot of good treatments, and we're so fortunate that we've able to then, you know, apply for other drugs that Bruce talked about on compassionate access. So it's not like if you can't afford it, you know, that's it. There's quite a few steps before you get to that.
Yeah. So then David has written, are there synergies provided by using radiation therapy in conjunction with either a tyrosine kinase inhibitor or immune therapy? So the answer is we don't have any good evidence for that, David. Radiation therapy by itself can be quite helpful in patients, particularly with bone disease. So when the cancer has spread to the bone, whether that be differentiated thyroid cancer or medullary thyroid cancer, but there's not good evidence about whether the combination of external beam radiation with a tyrosine kinase inhibitor or immune checkpoint inhibitors is beneficial. There is a little bit of very much anecdotal evidence that sometimes if you irradiate some tumours, you get a reduction in the size of another tumour, which may be a long way away from that early, from the tumour that was irradiated. That's a phenomenon that has been observed in a number of different tumour types. It's certainly observed in melanoma. I don't think we really see it routinely in patients with thyroid cancer, although there are, I'm sure, in the literature, anecdotal examples of that occurring. But in answer to your question, no good evidence of radiation combined with the TKI or immune therapy being better than the others alone. So I don't have any other questions coming up on my screen. Oh, there's another one that's just popped up. Can fine needle aspiration on a cancerous tumour cause it to spread? Look, with regard to thyroid tumours, we don't really have any evidence of that, Margaret. So the answer is no in the thyroid. We may very occasionally have seen a subcutaneous cellular deposit occur that you might think, oh, did that come from the needle biopsy itself? But this is a really rare occurrence in thyroid cancer.
Oh, I think I'll just put my email in the chat, but I think the panelist has just said me that it only goes to the hosts and panelists. So it's just my name, Matti.Gild, and it's at health.nsw.gov.au. So that's just Matti.Gild, which you can see there at health.nsw.gov.au, or you can reach out to Gary and he can pass it on. Thanks.
Now, the only other thing, I went to the American Thyroid meeting, and I'll just touch on briefly. I certainly don't want to start an avalanche of patients seeking this treatment, though. There was quite a good session on the role of T3 triiodothyronine in patients who have been treated with thyroidectomy and been treated for thyroid cancer, who are being treated with thyroxine. There is, and I'm sure we've all experienced this in practice, a very, very, very small group of patients who don't do as well on thyroxine as they would like to do. And some of those patients may benefit from a trial of the introduction of T3, triiodothyronine. There was a little bit of data presented at the ATA meeting. I've got to say it wasn't strong data. It was presented by the psychiatrists, showing that there were improvements in some people with depression scores if they were treated with T3. But and just to emphasize, the vast majority of people do very well on thyroxine alone. The other thing, of course, we have in Australia now, which is making life a little bit easier, is L-troxin, which doesn't have to be refrigerated. And that is also another option that I think it's good to try to change patients to, particularly if they go traveling, because otherwise we've all received calls from patients who've been traveling somewhere and they call in a panic to say they've left their thyroxine in the hotel fridge. Can you write a prescription for them and send it to the next place that they'll be visiting? And I think to myself, oh my goodness, this is becoming a logistic nightmare here. So the advantage of L-troxin is you don't have to put it in the refrigerator. You can keep it with you. And of course, if you go traveling overseas, I always advise patients to put some of their thyroxin in their checked luggage and some of it in their hand carry, so that if one or other gets lost, they're not thyroxin free for any significant period of time. But look, if there are no other questions, and oh yeah, so Jay has written, has anyone in Australia been treated with dabrafenib? So the answer, Jay, is yes. Several people have been treated with dabrafenib, and people are being treated with dabrafenib and trametinib for the I-FIRST study, because it's dabrafenib, which is one of the drugs which is able to help turn on the sodium iodide pump. So some patients have been treated with dabrafenib. It is able to be obtained. Novo Nordisk, sorry, not Novo Nordisk. Matti, help me. Which company markets it?
I don't know. I don't know.
The same. Anyhow, it's one of the big cancer oncology companies, and they will provide it to Novartis. That's right. It's Novartis. Thanks, Jay. So it's Novartis in the US and it's Novartis in Australia. They, again, will provide that on a compassionate basis. It's a pretty rough drug, I must say. It does work, though. I've used it in one patient who became resistant to lenvatinib, and it certainly helped him for a while. He did experience quite significant arthritis, I must say, whilst he was on the drug. I've certainly treated him, and then I've had a couple of other patients in the I-FIRST study who've been on dabrafenib supplied by Novartis as well. So again, if your tumour type is suited to treatment with dabrafenib, it can be obtained. For HRAS. Yes, there is, but HRAS mutations are very, very rare. We've had one patient enter into that trial, and that wasn't a thyroid cancer patient. So that trial is still open, and it's open at North Shore, but we don't have any starters at the moment. So if anyone has a progressive HRAS-driven tumour, we may be able to help you.
Is it just HRAS, that trial, or is it K as well, or is just H?
It's K as well.
Okay.
It's a specific mutation within the RAS gene, actually. I think it's a G14Q mutation. So not everyone will be suitable for that trial. Another question popped up. Jay says, do I want to say anything more about other trials in Australia? Well, Jay, there aren't any other significant thyroid cancer trials open that I'm aware of. the major sites that deal with thyroid cancer are either in Sydney, Brisbane, or Melbourne. And we all tend to communicate with one another because we all send patients one another if one has a trial open and the other doesn't. I'm not aware of anything else in Melbourne or Brisbane. So look, I think if there are no other questions, Matti and I always enjoy doing these sessions, and hopefully you find them useful. I can see there are over 30 people logged on to this one today. Gary was a little bit concerned initially that there might not have been a big attendance, but I think this is our usual number. I'd encourage you, obviously, if you have very specific questions, to reach out to your own treating physician, whether that be an oncologist, a surgeon, an endocrinologist, or a radiation oncologist. And if there are people who you know of who you think may be suitable candidates for any of these trials, or people who are on lenvatinib particularly, or selpercatinib, who may be able to participate in the acquired resistance study that Matti is leading, then we really would like to hear from you, because it is participation in studies such as this that ultimately will lead to the development of a better understanding of how patients with these mutations fare. But most importantly, we can then point to these new mutations and say to drug companies, go away and make new drugs to block these new mutations. So I would really, through the patient support network, I would encourage you to get the word out about the acquired resistance study, which is being supported by ITOG and led by Matti and Rory, because the more patients we have, the more robust the data will be, and the faster we're going to be in a position to develop new drugs.
Is there any chance for participants in the US to be included in that?
Yes, of course. In fact, Matti can rattle off some of the sites. Certainly I know Boston, Nebraska, Sloan Kettering are all involved.
All the big centres, MD Anderson, Mayo Clinic, yeah, anyone, we'll ask all those people to be participating. Absolutely, they've all signed up.
Do you know if University of California, San Francisco is included in that?
Just give me 1 second, I'll tell you. Mass General, MD Anderson, Nebraska, MSKCC, UPenn, UVA, Ann Arbor, yep, UCSF, yep, Ohio State, University of Michigan, yeah, which is really great. You know, you guys are fantastic to join. All those countries, all those centers, great to join in.
Any other questions before we sign off?
So I just had a comment back from Jay, who's saying he's in New York and he's been on dabrafenib for 3.5 years with only mild side effects. So that's great, Jay, and hopefully other people will have a similar experience. So look, thank you all very much for participating today. It's a bright sunny day here in Sydney, so we're going to get out and enjoy it. And hopefully the rest of you can do the same.
Thank you for your time, Dr. Robinson and Dr. Gild. Appreciate it.
That's all right. Thank you very much. And say hi to Gary for us.
Will do.
Thanks. See you later. Bye.
Bye-bye. Bye.